Good afternoon, everyone. We're delighted that you're here. We're going to give people just a couple more seconds to get started and to join, and then we will go ahead and get started. All right, welcome. And we want to thank you for taking time out of incredibly busy schedules for you to be here this afternoon with Kathy Lee Bishop and Guru Patel to talk about automatic referral in the context of a Cerner EMR system. So thank you for joining. We are going to rely very heavily on the questions and the comments that you submitted when you registered for the event, because we really want this event to be driven by you in the audience and to answer the questions that you have, respond to the concerns or frustrations that you're experiencing as you implement automatic referral. I want to just acknowledge that we have on this call both people from the first cohort of TAKEheart that have already received the training in modules 5 and 7 related to automatic referral. And then we know that we also have some people from the fall cohort that really haven't gotten to the modules on automatic referral yet. And we thank you for joining. There may be some very basic questions that we'll just point you to the resources for rather than taking time on this call to do. But we're going to do the best to support all of you. For those of you from the fall cohort, we're glad you're thinking ahead. We're glad you're starting to wrestle with the issues of automatic referral, and we want to do the absolute best that we can to help you get off to a good start. To get your feedback during the event, we want you to use the chat function, and you can see the instructions on how to do that. Feel free to enter a short greeting to the group. If you've got another question that you didn't think of when you were registering, you can enter your questions into that chat, into the chat now or at any point during the event. Just make sure that you pick as the audience everyone. If you just pick the attendees, then us as the panel will not be able to see your questions, and we want your peers to be able to see the questions as well. So please use the chat throughout the event. I know that some of you are on and you just want to listen, and that's perfectly fine. And I know that others of you are on and you've got some questions that have been agonizing you for days, weeks, months, and we're happy to answer those questions as well. So as I mentioned, our two panelists today are Kathy Lee Bishop, who's a clinical specialist and the program manager at Emory St. Joseph's Hospital and of their cardiac rehab program, and Guru Patel, who's the director of clinical informatics in the Office of Quality and Risk at Emory Healthcare. So both of them have experience implementing automatic referral in the context of a Cerner environment. And I won't say that, both of them have the gray hairs to prove it, since neither of them do, but both of them have plenty of life experiences that they're happy to share with you on the call today. So having said that, as we look forward, we took the questions that you and your comments that you gave while you were registering, and we tried to group them into 6 categories. Some general process questions, and then some questions about diagnostic codes, embedding automatic referral into order sets, and you see the other 3 categories here. So we're just going to kind of work through the questions in that order. So if you've got a specific question that you want to ask about one of these categories, we want you to know what's coming up, and you can, enter your question or look for us to answer your question within that category. Not all questions can be perfectly grouped, so we might put something in a slightly different place than you're expecting. But in general, that's how we're going to handle the event. And so we're now just going to start with some general process questions that were circulated during the during your registration process. So one of the questions was basically, what do we do first? Or how do we get started? And module 5 on automatic referral is our best answer to that question. And we really want to encourage you, if you haven't You can download that. The last slide that we'll be coming to in a few minutes actually gives you the link to that slide module, as well as the module 7, which is also about automatic referral. So by all means, that's a good place for anyone to start. But let me just turn to our panelists now. If you can think back to the time when you were starting your process of implementing automatic referral, do you have any just practical suggestions for people that are approaching that stage or in that stage now about, first steps and any particular things to do or not to do as you're getting a successful automatic referral implementation process started?
So I'll go ahead and go, at least for my part, because I work on the clinical side. What was really helpful was finding a physician champion who really supported the process, and we saw the value in it. And then from there, we built the team, and that team was pivoted around the IT department and having someone from nursing informatics be the liaison as we developed it, but also looking at giving the people who deal with order sets when we received the orders, the frontline staff, their input on this, that no one was eliminated. We wanted to hear everyone's viewpoint, even the nurse at the physician station, and how could this be incorporated. So we really had a core team, but then that core team tried to really get feedback from the end users and whether it's the physician putting the order in, how is it going to work in in a physician's office where the nurses have been the primary people to put the orders in. How is that flow going to work? So for us, start with the core team, and then we really looked beyond it. Who is going to be impacted by this process?
All right, thanks. And Guru, when Kathy or someone in her situation walks in and says, I want to get a project like this started, what's your tactical advice for them to be successful and enable everyone to be as efficient as possible?
So one of the big things that made this project successful was the requirements were laid out fairly well. They were not laid out in a technical manner, but even though from a clinical standpoint, people had, Kathy Lee, our physician leader, Dr. Goyal, they had a clear idea of what they wanted to do. And the other nice thing was our physician leaders were ready to dig in and put some work towards what needed to be done. So whenever somebody comes to us and says we need some kind of technical magic to happen, we always come back and say, what do you want done? What are your diagnosis codes? What are your workflow requirements? So our physician leaders actually spent a lot of time giving us very specific details around diagnoses, around workflow, around order sets, so that from a process standpoint, I think everything Kathy outlined, but then making sure that you have leaders that are ready to put in some work to clarify things when your technical teams have questions goes a long way in a successful implementation.
So you would completely agree with the statement that the IT department does not implement automatic referral by itself?
No, no. They. I'm sure they can, but that would not be a successful implementation.
And I'll just respond to that too, Steve, in that no one does a project of this magnitude alone. You need a team.
Yeah, thanks very much. And for those of you that are from smaller facilities, the number of people that you may need to involve may be a little bit smaller. What Emory did in terms of making referrals to multiple facilities may be more extensive than what you need if you're just focused on referrals from your own hospital into your own cardiac rehab program. So it is a challenging activity no matter how you do it. But in a small hospital, you're going to find that it's not as complex and even possibly as take as long as what a large facility might need. One of the other questions that falls into this category, and by all means, If you have questions, follow-up questions, put those in the chat at any time. But there's a question about, so what data do we actually need? And again, here, I want to point you especially to the implementation guides for modules 4 and 5, because those resources, which you can get, and I think the last slide actually provides the link, they're on the TakeHeart website. And basically, you know, the ICD-10 codes that are associated with each one of the qualifying conditions are provided in those documents. And you know, so that's a great place for you to start. And even the data assessment activity that you've been exposed to if you're in module 1, hopefully you've done that already. If you're in the first cohort, hopefully you've done that already. If you're in the fall cohort, hopefully you're working on that now. But that takes you through a lot of the questions to see, do we have the data that we need to implement automatic referral and support care coordination. So we want to point you to those resources. But then, you know, another question that came up is roughly, you know, what makes Cerner different or better or worse than other EMR platforms for implementing? And this is not a sales pitch for or against Cerner, but if there are some like unique characteristics that people that may not be familiar with it should be aware of as they go to implement automatic referral, what would some of those things be that you would mention to them?
Kathy Lee, I can take this and then maybe you can add something. So there are a couple of nice things within Cerner, and I even within Epic. So this isn't unique to just Cerner, but a couple of nice things that Cerner lets you do is if you have a referral that is within your organization, it's fairly easy to create a task for somebody and just give them a little tickler that, hey, there's a referral for this patient, please work that. Cerner can go a step beyond, and you can even send things outside of Cerner, triggering off of a physician order or a note or something along those lines. So the nice thing with Cerner and even Epic is you're not confined to just your organization. They actually have the ability to push things outside of your organization as well, without that organization having to be on some kind of HIE or some kind of a data exchange platform. Of course, you're always concerned about PHI, and you have to make sure that everything you do is HIPAA compliant. But then that's one of the benefits of having Cerner or Epic versus a couple of the other systems where you don't have a way to go outside of your organization. Within Cerner itself, there are some nice tools available if you have your Cerner configuration set up where you can identify a cardiologist versus an emergency room physician versus an hospital medicine physician. You can design alerts and triggers that work differently for different roles and different clinicians. These are some of the things that you can leverage Cerner for. And actually create focused alerts and decision support tools that can help you get better buy-in for something like this, any kind of technology like this.
And I'll just respond to that too. One of the things that was important to us is because we're a large healthcare system, like how can the documentation travel with the patient? So we wanted to make sure that once the referral was put in, that it became part of the medical record. So if someone 90 miles away was at a clinic outside, could actually see an order had been written, who it had been written by, what were the ICD-10 codes. And so that if it was really beneficial to have it be a way to communicate across a vast system. And I really like that. The other advantage that making that multi-system patient task list. So when we think about our system, we had at the time, we only had 4 hospitals, but we still had over 100 clinics. it went to a central place. It went to a central information port, which are that task list, which then allowed us from a central location to then send out the referrals where they needed to go, which was really nice, and contact the patients, because our patient network is multi-state. And so it was very helpful to have it be so easy to communicate with us. I don't know what you did, Guru, but you clicked something to make it real easy for us to be able to reach patients who had gotten orders. So
Yeah, thanks very much. We got a couple follow-up questions in the chat we may as well discuss. One of them deals with tasks from Courtney. How's a task set up once a referral is made? I've been told I need to go into the ambulatory order management tracker and I can't get a notification that it was placed. I was trying to get a work list set up, but was told that wasn't possible. Guru or Kathy Lee, can you help Courtney out?
Within Cerner, there's a tool, and this is one of the older tools within Cerner called multi-patient task list. It works really well for something like this, where you have an entire organization feeding into one group of referral management team members. We leveraged that multi-patient task list functionality. And so our referral management design was based on Cerner orders. And it was then at that point easy for us to take the order, create a task, and then drop that task or design that task to go on that multi-patient task list. Some of the things that you always have to worry about with multi-patient task list, the users of that list, you have to make sure you know what their Cerner roles are and they have the right security to be able to see and work those tasks. That was a big pain point for us because we weren't very religious about our Cerner roles prior to some of these projects, and we learned a very hard lesson about role clarity within the Cerner EHR. So the electronic roles and security was a big deal for us.
just to build with that, once if you do establish a multi-patient task list, you actually need to have a workflow from it. What do you do when you have a patient land on that task list? And one of the things that our IT department did so well, it was instantaneous. So any doctor that put in an order or it went automatic, it immediately came to our list. So part of our workflow was we were calling patients when they were still in their bed in the hospital. We were so efficient. And so we had to work the workflow on the back end to make sure that the patients actually got to be discharged before we called them, because it was so efficient. We actually had to say the words, just slow down, breathe, and now call the patient. So.
All right, thanks very much. We've got a couple questions coming up on ambulatory referrals. So we'll get to Andrew's question on that in just a few minutes. Several people had questions about, at present our system, they still have to check a box, or we've got orders set up but no automatic referral. Or even, we've got a paperwork process, but we're struggling with that. What should we do? So any advice for hospitals that may have like some of the elements in place they need for automatic referral, but it's not fully automatic yet? What do they need to do, and how important is it for them to do that?
So I think the one thing you mentioned that people are not checking the box, or it's part of the order set, but it's not utilized as much. Cerner has a couple of functionalities that I think folks can leverage. So within Cerner order sets, I think they call them power plans. So within Cerner Power Plans, there's a function for linking orders. And then when you link them, you can design it such a way that if the physician bypasses that, there's a gentle nudge and the system says, hey, maybe you forgot to check one of these. And that prompts your physician to check that box. Unfortunately, there's no report within Cerner that tells you how effective that box is. I wish there was, but there isn't. So you just hope that that nudge works. Now, the one thing that we did was, and this is where our physician leaders and Kathy Lee and the team was very helpful. They helped us design something where, based on the current problems list and diagnosis list, if a patient is being discharged, so physician's about to write a discharge order, we know what their problems list is, we know what their diagnosis list is. If the physician group has not placed a rehab referral order on that chart, we designed an alert system that effectively hard stops them at discharge. And they have to either say, yep, here's a rehab order, or here's why cardiac rehab is contraindicated. So you get one of two choices. And that, I think, really closed the loop for us, where we gave people an option to do it on their own. But if they did not do it on their own at discharge, based on certain criteria within the chart, we locked it down and said, you either order a rehab or you tell us why you don't think it's needed. And then those are data points that we can actually query and report out on. So in terms of physician checking, not checking, we sort of close the loop so that at the end of the process for the patient, physicians don't have a choice.
And I'll just add a quick statement to that. So I'm actually the nudger for our system. And so we're actually, because of the way we designed it, we are able to track how many physicians and which physicians frequently do the bypass. And we're able to do, I'm able to do education and try and figure out what happened and was it appropriate, wasn't appropriate, what could we do to be more efficient to help the physician at the front end. So even though the tickler is there to do a hard stop, there's still like a little way of kind of getting around it, but we are able to track that. And I get reports and I'm able to follow up just to find out, you know, what's happening, how can we better help you use our referral system.
Right, and in response to Lisa's question, the codes that I was referencing, that's what determines, you know, what triggers the automatic referral. A couple just clarifying questions, Guru. What is a multi-patient task list? And then can you just confirm for Courtney that, you know, all of the CRs in their system are going to go into the task list from any place within the system?
Yes.
Yes, they would. And multi-patient task list, effectively, Cerner has a nursing task list that your med orders, your certain patient care orders fire a task. Now, the typical task list is a patient-specific list. So you go into that patient's chart and then you access that task list. Whereas the multi-patient task list was designed at the organization level, where if you click a button and you can see multiple patient tasks on that same list. And that's where you have to be careful about how you design a particular task, because you could actually flood the system, and it effectively can crash if you don't design it properly. So yes, it's a great tool, but you just have to be careful with your design.
All right, thanks. And there's a couple questions about outpatient referrals. We're going to get to those in just a couple of minutes there. One of the questions that we got in the registration list is, how do we handle missed referrals that aren't identified until after the patient is discharged? So presumably a part of that is really having an automatic referral system in place. But are there any other insights that you can give to the person asking that question?
So I can say that I was involved in a lot of education. Like we did our best to make sure we caught everyone. But then we worked with, again, Guru mentioned that we have over 100 clinics. We worked with the cardiologists in those multiple practices to say, can you ask this one question when the patient comes to do their follow-up from the hospital? Did you start cardiac rehab? And so our outpatient sites also have the ability to do an automatic, I mean, not an automatic order, but do a cardiac rehab order from those different clinics. So our education was one question, not a trigger. And I think if we had kept going with Cerner and had that chance to go that next phase with it, we would have done that. We would have put it on the ambulatory side. But did you start cardiac rehab? Not are you not, but did you start as the conversation?
All right, thanks. One more question before we get to automatic referral to outpatient settings. There was a question, who's responsible for support and maintenance of the automatic referral system once it's implemented? And typically in organizations, the answer to that question is somebody else. But what's the correct answer?
Well, for any system like this or any design like this, I think there's three components, and for us, most of the times they work very well. There's the clinical component, there's the informatics component, and then there's the IT or the technical component. And so, as long as we have identified owners of all three, the maintenance is not a problem. We struggle whenever one of those three prongs does not have an identified owner. And then we sometimes would spend a month or two or three trying to figure out who actually owns one of those prongs, and how do we bring them up to speed on what has happened in the past. So I think that's my answer to almost every one of these questions about a system or a process like this.
And I can say during our team meetings, that was brought up of what's going to happen once it's up and running and who's going to maintain. And we did divide it that way of who was responsible for which component. And because I sat on the clinical side, we took ownership of that side of it for this process.
All right, thanks very much. Let's move now into, we've got several questions related to how you handle referrals to outpatient settings or to even, practices that may be outside of your system or hospital. So your thoughts on that, and then we'll get to the specific question related to referrals for heart failure patients from outpatient settings.
Guru, do you want me to go with this one or are you good?
Sure, yes.
So the challenge is, at least within our healthcare system, here we are with this massive healthcare system with only 2 cardiac rehab programs. And so the benefit, and anyone who works in cardiac rehab, we're all there for the patient and trying to be best for the patient. So we built in, once the person came on our multi-patient task list, we built in our communication tool of 40 regional cardiac rehab programs outside of our system. And so when we reached out to that patient to try and connect them to a cardiac rehab program, again, outside of our system, but more convenient for them to go. So part of my maintaining my leg of the process was that we update those 40 cardiac rehab programs as they turn over. They've got new contacts, but that's what we did for patients outside of our range. And so the 2 cardiac rehab programs in our system are about 10 miles apart, but the Emory Healthcare foot reach is multi-state. And so we wanted to make sure that was part of our communication right away for patient-centered care.
Thanks. Let's now turn to CHF patients and just referrals from outpatient practices versus the hospital. Your advice on setting up the system. I mean, the codes are clear, but the process can still be very challenging, particularly if the practices are not necessarily on the same EMR as your hospital. So advice on how to handle that for the people that are interested.
So when the IT were wonderful and they built this automatic referral, they also built that you could do an ad hoc referral. And so we did education at the multiple heart failure clinics that are part of our system, that they could do an automatic, or not, they could do an ad hoc order for cardiac rehab with the same exact power form. So it was click, 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 down, hit the down arrow, load in the ICD-10, have all the medical necessity right there. So part of my job on the clinical side was to do education of how do you do that on the ambulatory side for all of the different heart failure clinics that feed into our area.
One of the struggle with ambulatory workflow is it is so quick. The patient comes in and out within sometimes a matter of minutes. And so in the inpatient workflow, we have at the end of the process at discharge, we can lock the provider down and force them to make a decision, uh, even if it's a soft stop. But in the outpatient world, that's very difficult. So one of the things that we did was in the Cerner design with the QOC, the quick orders and charges page, we tried to put the rehab referral order and the contraindication order face up so the providers can actually see it. So when you're on your quick orders page, at least it's in front of you. We can't force you to click there, but we can make it visible and available all the time. So not a whole lot of boundaries you can draw for your providers, but you can at least nudge them and show them that order all the time.
Yeah, thanks very much. And the consensus from, experts that we talk with on this project is that it is harder to get the referrals coming in from outpatient settings. But having said that, the benefits of cardiac rehab for heart failure patients are substantial. And so, just because it's hard doesn't mean that it's something that you should not really try to do, because it really can benefit. Sometimes the patients that may seem the sickest and frailest benefit the most from cardiac rehab. So we're really happy to see that you're thinking about those patients, and encourage you to continue to do that. We're moving now into some of the questions about roughly embedding automatic referral into order sets. And there were several questions similar to Rhonda's in the chat about APPs needing a co-signature from a doctor. And when the order is printed, the physician's signature isn't showing, or maybe it's somebody else's signature that's coming. How do we make the right signature show up so that everything works?
So I'll take a stab at this from a technical standpoint, and then Kathy Lee, maybe some workflow discussion. But from a technical standpoint, our APPs are required to enter a supervising physician when they place the order. And within the Cerner design, we can then flip-flop between whether the supervising physician has to co-sign that order or not. It puts a burden on our IT team to keep that up and make sure that every new order build is correct. But it definitely works with compliance, where an APP that enters the order, when it's designed correctly, it goes for the physician co-signature. Now, in terms of printing physician signature, one thing that we've done for a lot of these orders is if it ends up with the physician for co-signature, then our reports, our printed orders, actually have the physician signature at the bottom in an electronic format, of course. But when we've sent an order for verbal or co-signature to the physician, our order report that prints out from Cerner actually shows that on the order itself. And so when you look at the order, the physician's name and the signature's there.
All right, thanks. And then a variant on that question is, how do we keep the emergency department physicians from placing orders as opposed to the cardiologists?
I think that boils down to the security settings. So if all your physicians have the same security setting and they all have the same role within Cerner, it's going to be difficult unless you can somehow figure out based on the patient location. So one of the things that we've done at Emory, we can always use the patient location and hide certain orders or show certain orders depending on the location. But we've also got our physician security is set up so that we can easily identify an emergency physician versus a cardiologist or anesthesiologist. And so when we design some of these decision support alerts, we make sure that we don't show them to our ED physicians. Sometimes we don't show some of these to our anesthesia physicians either. So depending on what alert is appropriate for what patient location or what physician, we now have the freedom to design accordingly. About 10 years ago, we didn't have that freedom. It was a lot of investment for us to actually find all our physicians and put them in the right security role, but then it gives us freedom to customize our alerts much more granularly.
All right, thanks. And there's a question, what program can we use for generating orders for phase 2 in Cerner and have the MD fill out and send to the program automatically?
Kathy Lee, unless you know, I may need clarification on what that means.
Because when the whole automatic referral is to phase 2 in our system. If they wanted something inpatient, that would be our physical therapy and OT orders. But the way this system was designed was to directly go to our phase 2 cardiac rehab program that we have on the ambulatory side. That's what this all loads to.
Yeah, and we'll get to in a few minutes, because there's some questions from programs that, you know, their hospital has an EMR and their hospital may have it's set up for automatic referral, but their specific cardiac rehab program isn't connected to that, and advice for them. So we'll get to those questions in just a couple of minutes. But there is a question: how do we get the inpatient elective order to be able to be seen in a future outpatient encounter without having to print it and scan it and do some other things that we know frequently would be overlooked? So any advice on this?
Well, I think, Guru, I think later if we have a little bit of time, we actually had some screenshots of once the order's been completed, it actually loads up to a document within the patient's chart. So we don't even look at orders on the outpatient side. We have the order has filled out in this gorgeous documentation that goes under clinical notes, under cardiology, and it stays with that patient across our whole system so everyone can see what that is.
Yeah, and we're happy to scroll down to those slides now. So do you want to just tell us which slide we should be on, and we'll be happy to point it out happy to let you comment on it.
I think that would be the last slide 17, if I'm not mistaken. One of the later ones.
No, sorry, it's going to be
oh, right there.
There. I think it's number. Yes, there we go. And so the way we asked for this to be designed was that because not all of us are really quick in EMR, and so it's a little bit easier when you go to a clinical document that you're trying to gather information from the patient. And so we designed it so it would go documents by specialty. The next link was cardiology, link to cardiac rehab, and then there's the order. So the order's in the order system, but it was just so much easier for all of us to see it as a full document to be able to utilize that. And also it helped us with insurance challenges too, to have everything right there in the document.
So from a technical standpoint, we were able to get this done because the physician is filling out a power form, and then we take that power form and render it into a clinical note. and everything you see here was reviewed over and over by Kathy Lee to make sure that our technical team is designing it so that it would meet their insurance and compliance requirements. So it was the order that triggered a form. The form was filled out by the physician or APP, and then that landed into a note that can be used as an order at a later date.
And Steve, if you want to go back and maybe slide number 12, which actually shows what the power form is. I think it's number 12, maybe.
One more. There we go.
This one right here. So this is the power form that we were talking about. that once you click the diagnosis, then you click down to get the ICD-10 code. This information here, the way IT designed it was it then formulated that wonderful document in clinical notes, which was, so it took kind of like this click here, 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 but it made it into a nice fluid note.
All right, thanks very much. And we are sharing these forms. And if you're looking at that most recent slide and saying to yourself, I need to get my eyes checked, don't worry, it's very small. But when you get the deck, you should be able to see a little bit more and expand it to the full size of your screen. And I think Sherry Lee's following up on that, saying that is that true for all versions of Cerner, including Community Works, or I don't know if you know the answer to that question.
Well, Community Works, that's a unique setup. So that is a challenge in itself. I think you have to work with your Cerner representatives to get this built out. The technology that we've used is one of the older, in my opinion, more reliable technology. So it's Power Forms, multi-patient task list. So none of that is difficult to get. It's just that when you're with Community Works, you have to work with your Cerner reps and resources to get the work done.
All right, and then Martha had a question for the outpatient cardiac rehab facilities. Do they actually need to print the referral order and then scan it into their encounter, or can they just use the electronic order that's placed inpatient?
So this power form is the same thing that IT put on the, I'm sorry, Guru, what did you call that? That other, so I use the right language.
The multi-patient task list, or?
No, like, so on the, for an ambulatory physician.
Oh, the orders and charges page.
Orders and charges page, yeah. And so this is, you could just type free text and then make it one of your favorites, especially if you're a cardiology practice, and this power form will come up.
If you scroll up, you can see the couple of orders that we use here. They are right there. So this is it. So if you all can see the first order cardiac rehab referral, that order is what pops up the power form. And if the provider wants to say that the patient's contraindicated, then it's the second order they use. They get a second pop-up that forces them to select one of the reasons for contraindication. And this screenshot that you saw was for the inpatient workflow, but we took those two orders and put them on the QOC page for multiple specialties. I think family medicine, internal medicine, and cardiology in the outpatient setting. And so they can easily access these two same orders from their outpatient screens.
All right, these are great questions. I mean, the questions coming in from the chat and on the registration page, they're very rich. We're going to move now into some questions related to engagement and buy-in and training. And there's a couple of questions that are how do we get the physicians to actually put the order into Cerner? Obviously, automatic referral is designed so that they may not necessarily need to do that. How do we get staff to click the box for the order? And just more generally, how do you, get the cooperation and support and understanding from the clinicians that you really need to make the process work?
So a couple of things, and I'll address it from my side, is that we actually got one of our marketing team members involved to talk about what's the best way to reach the front user, which would be the physicians or the APPs that are going to be using this in the hospital system as well as the ambulatory. We spent a couple months designing how it was going to be rolled out. What does the education look like? And then what happens once that group of physicians have left? How do we keep this up? Because that's the thing, it's sustainability. You just can't do it once. We have, because we're an academic teaching center at some of our hospitals, we have academic physicians that rotate in and out. And so again, the education can't stop. It actually has to be ongoing. And then same thing with the ambulatory side. It has to be ongoing when there's turnover in that physician's office of maybe they're not familiar with it. Well, we're more than happy. We've got the original rollout plan from marketing, which was just very nice step by step, what happens in ambulatory, what happens in inpatient. And so working and having a consistent message, and then that ongoing, it doesn't stop. It has to keep going if you want to keep this sustained.
From my standpoint, from informatics standpoint, one of the nice things that Kathy Lee and Dr. Goyle helped us design was the whole thing about contraindications. So a lot of the times we push providers and physicians to say, give me a referral, but we never give them a way to get out of it. And so this was a good design from our standpoint, because it not only said give us a referral, but it gave them an option to say, what if your patient's contraindicated? So this was a good selling point for services like hospital medicine, where uh, we don't want to bother people with alerts and pop-ups. If they could just go bypass and say, man, no, go move forward. They were really convinced that this was useful because they could document contraindication, and it was meaningful. It actually allowed them to say something about why they're not ordering rehab referral. So from that standpoint, because the design was neat and clean, some of our hospital medicine leaders were easy to convince, and then they sort of came on board with it quickly as well.
And with this list, we brought in the front users. We brought in physicians from different services to get what would you consider, in your opinion, and then we went with what, with Dr. Goyle being our champion, what's realistic when you think about cardiac rehab. And so having, again, bringing the people that are going to use it and how that's applied in real time was very helpful.
Yeah, and there's a follow-up question from Kathy Briggs on how you move an order from an inpatient encounter to an outpatient encounter.
Well, so in our design, the order, the actual initial order was just used to trigger the power form, and then the form essentially created a referral order that could be used at a later time. So when we built this, when we designed this system, orders to scheduling was not a robust enough Cerner tool. And so we could not leverage orders to scheduling. And so we ended up having to create an order that lives in our clinical note section that is later utilized by Kathy Lee's teams for the referral. Now, if I had to redesign this, I would actually just create an orders to scheduling workflow out of it, and just leave clinical notes completely out of this. But in the day and age when we built it, orders to scheduling wasn't robust enough.
All right, thanks. And then moving into another engagement, buy-in, training question. What about the providers at facilities that are outside your system, not on your EMR? Any suggestions? And obviously, this is not automatic, but any ways that you can or have tried to educate them, engage with them to encourage them to make referrals to benefit the patients?
So that has been a challenge, and it continues to be an ongoing challenge. A lot of the cardiac rehab programs, so I mentioned that we try and reach out to 40 of them within our region. A lot of them will not take an order from Emory Healthcare. That's been automatic. They have their own QR code that has to be sent back to the physician. But at least what we're trying to do is connect the patient to that practice, and then that practice can go ahead and use their process. What we found is even the ones right here within a 5-mile radius, each one of them have the QR code. It has to be on their documentation to be then scanned up into their own electronic medical record. The dream is for all of us to be on the same electronic medical record at some point, so our patients can move smoothly across the system, because at least in Atlanta, travel is a challenge, and patients don't want to come in close to the city. So they do want to go to cardiac rehab out in the outer perimeters. So is an ongoing process. We have not solved the problem, but we've tried to mitigate it as much as we can for our patients.
Yeah, thanks. And there are a couple other questions related to the same sort of coordination, but not outside, but inside. One question relating to, getting things through pharmacy or engaging with other departments that may be involved with the automatic referral process. Any concrete advice on how to make that work the most efficiently?
I think it's a question of ownership. The Even with strong ownership from Kathy Lee or our physician champions, this took months to get done. So if you have order sets where you have pharmacy components, the thing that works for us is for all of our order sets, we have clinical pharmacists that have been identified. Of course, this is a recent thing for us, but everyone in my department, in my group, we all know which pharmacist to go to, or we know one pharmacist that can direct us where or who to reach out to for, let's say, a cardiology order set, go to this person. So we are getting there. We're getting to a point where we have nursing champions, pharmacy champions, and of course, physician champions identified for each order set. And that's a lot of work for those champions to keep up with it, but it helps when you have changes that you want to make.
And then I'll just add one quick sentence. It took us 22 months from start to full implementation rolled out across the system. So I don't want anyone to think that Guru and I sat in a room with Dr. Goyle, we made this happen. It was a 22-month period of going back and forth, testing, piloting to really come to this. And also the ICD-9 codes changed to ICD-10s just before we originally were going to implement, and we had to do a reconstruct, rebuild for that.
Yeah, and one of the things that you did that there were several questions about is you figured out how to make the referrals go to the right facility that would be the closest to where the patient lived. And there are several people wondering, how do you actually do that? So any advice for them on how you can set that up?
So do you want to address it, Guru, via Cerner? Because I'll address it what we're doing.
Right. So from a Cerner standpoint, the referral goes to one location. Well, so let me rephrase, to one electronic location. So the referral notification goes to a multi-patient task list, and it's a centralized list, and it could get long. So the request from Kathy Lee's team was that all of the referrals from all our hospitals and clinics, they need to land in one spot, and then Kathy Lee would have team members manage that list. So because that was our request, we created a multi-patient task list with everything going to one. Now, the multi-patient task list does have the ability to filter by location. So if we have 5 hospitals and we have 5 different groups looking at this, we can easily filter the multi-patient task list to only show you the hospital or the clinic region that you would be working. So that was the other benefit of using a multi-patient task list.
All right, thanks very much. I'm sensitive to time, and we've got some questions about recording, or excuse me, reports that people want to generate. How do we get the cardiac rehab navigators inpatient notes to notify or draw a report for the outpatient facility?
Well, I think it depends on how it was designed. So I'll answer it in maybe a general sense, or at least from what we've designed. So because we designed an order and a form-based workflow, our data warehouse, we can easily pull out reports of whatever we need. Now, Multi-patient task list effectively acts as a report itself because it maintains a list of patients and you can filter back and forth. But if you needed to know how many providers documented contraindication, well, because it's an order-based workflow, you could always go back, whether you go to Cerner or if you have a data warehouse, you can pull order reports or form reports and figure out what data was collected or what data was missed. So that's how we designed it. I think, Kathy Lee, we designed it with reporting in mind when we first started the discussion.
So it was really important to us. So when you design the power form, you want to design something that has discrete fields to be able to pull that data. And so just like Guru said, we designed it from the get-go of being able to track percentage of individuals that use the power form, percent of eligible patients based on ICD-9 codes, contraindication codes, did they use internal versus external cardiac rehab? So from the get-go, we sat down with our team and said, what information will be important to us as a system to be able to show we're meeting the needs of our patients and we're meeting the needs of the staff using the forms. And so discrete fields were really critical in the design. I'm sure Guru wasn't happy with all the discrete fields we requested to have built, but it really helps us in the long run for patient outcomes, physician happiness, patient happiness, and staff happiness.
I'm all for discrete fields.
All right, and Andrew, sorry, just entered a question in the chat. What is the Cerner function called to transmit documents outside of the organizational EMR? And are those, Cerner functions or plug-in or third-party functions? So what can you tell them about what that's called?
Mm-hmm. So maybe a clarification first. Not necessarily documents. When I mentioned sending something out to an organization outside of your EMR boundary, what I meant was you could send them at least an alert or a notification, not necessarily a document. Now, you can get creative and that notification can turn into an order, just the same way that we took a power form and turned that power form using some fancy text rendering into an order. You could create something that goes out as a notification and turn that into an order. And so for Andrew, I think within Cerner rules functionality, there are certain ways that you can actually fire a rule that sends out an email. And that email can contain the information you need out of your chart. Again, you always have to be careful about PHI going outside of your organization, but if you satisfy those requirements, that email can contain everything you need to draft an order, and that can go wherever you want. I mean, it can go to your Gmail account, but again, it's PHI. So that is a flag that I always raise when I talk about emails going out.
All right, thank you very much. And I think I can say with great confidence that we've, thanks to Kathy Lee Bishop and Guru Patel, answered a large majority of the questions that have come in either during the registration or in the chat this afternoon. I can also say with great confidence that we haven't answered them all, and we've done our best. Many of the questions, give us step-by-step examples or additional information on how to do things. We really encourage you to take a look at those at the modules 5 and 7, or review those if you've already been exposed to them. They're still coming up if you're in the fall cohort, but they have a lot of the applied advice that you may be very interested in, and we encourage you to do that. And then we'll review these as has been said in the chat. We will circulate the slides and the recording of this event so that you can review it or provide a link to it to others in your organization. And we'll go back through the questions, and if there are any specific ones that we realize are really important and we weren't able to answer them today, then we'll try to answer them we're compiling questions and answers across the 3 events that we did, and we'll try to put that together and make that a resource for all of you as well. So my thanks again to Guru Patel and Kathy Lee Bishop for their work, their excellent examples, and their willingness to answer your questions today. And thanks to all of you for taking time to learn about this important topic in an environment where we know that things are very busy and very challenging. So thank you all very much and have an excellent rest of your day.
Thank you.
Thank you.